Hello and welcome to our very first episode of podcast series titled For the Communities Grand Cyclate Under 8 Minutes. I am your host Chinmay Kumar from the Asia Pacific Regional Learning Hub. This is a critical time for us. Today we are tackling one of the most critical pillars of Global Fund portfolio, which is tuberculosis. To help us get straight into the must-know elements of TB priorities under GC8, I am joined by Dr. Jamie Tonsing, Disease Advisor for TB at the Global Fund. Dr. Jamie, welcome to the podcast.
Thank you very much for having me. It's a pleasure to join today.
Thank you. Dr. Jamie, to save time, my first question to you is, what is new or different in Grand Cycle 8 for tuberculosis?
For Grand Cycle 8, I would say the big change is what we call the strategic shifts for Grand Cycle 8. And there are several elements to it. I think firstly, it means really moving money to lower income settings where the disease burden are very high. It is clearly laying out transition pathways for countries to transition to domestic budget instead of global funding. This means actually that there will be some countries for which the next two grand cycle will be their last grand cycles, and then there'll be more more attempts in the coming years to work towards building self-reliance and sustainability. The other changes I think are all related to or changes and strategic shifts are related to rigorous prioritization, innovation, integration, value for money, community systems, and sustainability. You will hear this a lot throughout as we really tackle how we build and develop the GC8 funding requests and prioritization processes. So what this means in practical terms, for example, is the Global Fund guidance that will clearly have interventions categorized into what is high priority for global fund investment, what is low priority for global fund investment, and what are the things that we should consider for optimization and efficiency. That's one on the guidance itself. The second element is you would have seen that in past cycles we had a CRG, Community Rights Gender Technical Brief on TB, as a standalone document. This time, it's not a standalone document. Elements of CRG that are critical to TB response are part and parcel of the TB prioritization guidance. And so this includes things like how to address the needs of key and vulnerable populations, community systems and response, and barriers to access services faced by the most vulnerable people. And a last thing maybe I would say is that for the first time also we're looking at, we've expanded the scope of what we term key vulnerable populations to include people in fragile and conflict affected settings, and also to include climate impacts. People, for example, are affected by extreme weather events, and because they face food insecurity, their livelihoods are disturbed. So what do we need to do to make sure people are included under key vulnerable populations and meet their needs? Over to you, Chinmay.
Thank you so much. So my next question to you is that what are the core pillars of effective TB program?
In terms of the core pillars, I think I would frame what we call at the Global Fund TB program essentials as core pillars of the TB program. And these are basically a set of interventions based on, they are standards, they're based on normative guidance from WHO or the international partners. They are best aligned with what the key priority interventions for the Global Fund are in terms of the sense that we think if we do well on these critical standards or benchmarks, we'll make progress towards ending TB, meeting the Global Fund strategy goals as well as the NTB targets. So there are 13 such TB program essentials. They were introduced in Grand Cycle 7. And for this Grand Cycle 8, we've updated them, and then the number has increased to 15. They cover all aspects of TB programming, from screening, diagnosis, treatment, prevention, as well as cross-cutting areas. I think what we need to remember is, because the context, we have to consider country context when we are addressing these program essentials. For example, not all program essentials are equally relevant to each country. As an example, I can tell you that in some big high TB burden countries in Asia and Africa, engaging the private sector is critical because many people first go to the private sector for when they fall ill. Without engaging them, you cannot end TB. But it may not be the case in other countries where there's hardly any private sector practice at all. So that's how we went about it. I can give you some examples of what these program essentials are. I think one is really data-driven decision making. For example, this is a standard that we expect to see in every grants because unless you have a good system to rapidly generate data, analyze them, and use this quality data to improve programming, you will not be able to um, achieve the results you wish to do so. The other one is on innovations. I think we're really excited that there are many exciting things in the pipeline for TB. And as they become available and the things that are already available with us, how can we make sure they reach the people who need it most? Because if innovations don't reach the people who need it most at a scale that we want to see it, then it really serves no purpose. The other thing, there's also a standard around integration, and this is also one of I mentioned earlier, one of the strategic shifts, and we want to really see more integration of TB in primary healthcare settings. It also within the broader health system, because TB on its by itself is many dependent on a well-functioning health system, and so this is getting more and more critically important. Another benchmark is related to providing decentralized, ambulatory, community-based, and led people-centered services, and then using analysis of inequities to access TB services and have programming that reduce things like uh, stigma and discrimination reduction, legal literacy, and access to justice. Importantly, community mobilization and monitoring for and by people with TB and affected populations. Over to you, Chinmay.
Thank you so much for the third question, which is how should countries prioritize TB interventions?
Mm. So I think a good framework for how to prioritize is I consider is the value for money framework issued by the Global Fund, and this framework is hinged around three dimensions of value for money. It has to be, of course, whatever you prioritize you have to make sure that it is effective. Secondly, it has to be efficient, and thirdly, it has to be equitable. So what this means in short term is really choosing the best interventions that are available, delivering them to people who need it the most, always keeping in mind and avoiding um, waste, duplication, or paying too much for cost input. So I think that is the broad principle around which we should say these are high priority or low priority. If you want me to give examples for TB concretely, I can say um, we are prioritizing really innovations I mentioned earlier, but particularly new innovations that have been just recently recommended by WHO that can help save costs, a lot of costs. I'm talking about the near point of care test for TB, the test for which costs half of what we normally use as a standard of care right now. There is also a way to pool sputum sample and reduce the cost. There is also a possibility to use tongue swabs instead of sputum samples for those who cannot give samples, like children and PLHIV. So a lot of priorities towards these innovations that are great but save costs. Then there are also things like that are more sensitive things to do, but like the CAD, computer-aided diagnostic, or the AI software on chest X-ray. You don't need a radiologist. You can read it. It is better than asking for symptom X-ray screening. Making sure we use molecular tests because that is a better test, and at the same time deprioritizing smear microscopy for diagnosis because it's not sensitive at all. It misses half of the people who need to treat me. So those are the ones on screening and diagnosis. On treatment, we have shorter treatment regimen for the drug-resistant TB, for TB preventive treatment. So we should be prioritizing those because they are, especially the BPAL-M regimen for drug-resistant TB, because it is much more effective than other regimens and yet cost is much lesser, right? So on TPT, TB preventive treatment, we're saying the people who are most likely to benefit from this is children below 5 years who are contact of TB patients, people living HIV, So let's make sure we cover these population groups well before we reach out to other groups, given if we are in a situation of resource constraints. And I think unlike in the past when we used to fund expensive time-consuming prevalence surveys, those are going to be lower priority. We just have to find a more efficient way of estimating disease burden. So these are some examples. And like everything else, it has to be country-driven prioritization, and they have to consider the country context. So these are guidelines for my guidance that for countries to consider when they come up with their own prioritization process. And I should also say that what we are saying in our guidance of prioritization is for the use of global fund monies, but there's money beyond global fund, the domestic budget. It could be loans, or it could be philanthropy funding. So those are other sources of funding which they can use for things beyond what we think should be global fund investment should be used for. Back to you, Chinmay.
Thank you so much, Dr. Jamie. We sincerely extend our thank you for helping us navigate this critical shift. Please share these videos with either a CCM member, civil society leader, and a country networks, and stay tuned and informed about Grand Cycle 8. Also, subscribe now and join us on our journey. I'm Chinmay Kumar once again. Let's ensure we build this cycle with us and for us. I will look forward to seeing you once again in our next 8 minutes. Thank you so much. Stay tuned.